The majority of you have not met me before. I'll be lecturing actually for the first time tomorrow, the 3rd of October, to the 30th undergrad veterinary students. Yay! So I'm Dr. Rosia Sala, and I will be taking you through respiratory pathology over the next 4 days. And in preparation for that, I'd like you all to just go through these PowerPoint presentations. I've converted them into a video format. All of them are less than half an hour long. It will be to your own benefit because you'll familiarize yourself in a way to the content that I'm going to present in class, and then you'll be better able to apply the information and ask questions and make sure you understand what is being presented. So please do take the time and go through this. I'll try and be as clear and as slow as possible when I talk so that everybody can understand as best as possible. This here is the objectives page. It's literally just a copy straight from your study guide on exactly what is expected of you when it refers to lung pathology for a student in GOP 330, undergrad veterinary student, basically. So what I would like for you to be aware of is my approach to the lectures that I'm going to be presenting over the next 4 days. I'm going to concentrate more on application of the information and the knowledge that you would have already gained when preparing for the lecture, and how to apply that, and basically how to pass your oral examinations. That's what I'll be doing, because most of the time, if you'll see there where they refer to describe, distinguish, discuss, explain, it's usually concepts that are much more difficult than just simply reading and memorizing. And that's where I'll come in class. And so it's going to be quite important, and especially to your benefit, to actually attend classes. Okay. This here is the objectives page. It's literally just a copy straight from your study guide on exactly what is expected of you when it refers to lung pathology for a student in GOP 330, undergrad veterinary student, basically. So what I would like for you to be aware of is my approach to the lectures that I'm going to be presenting over the next 4 days. I'm going to concentrate more on application of the information and the knowledge that you would have already gained when preparing for the lecture, and how to apply that, and basically how to pass your oral examinations. That's what I'll be doing, because most of the time, if you'll see there where they refer to describe, distinguish, discuss, explain, it's usually concepts that are much more difficult than just simply reading and memorizing. And that's where I'll come in class. And so it's going to be quite important, and especially to your benefit, to actually attend classes. Okay. Briefly, what we will touch on when it comes to lung pathology is what the difference basically is between bronchitis and bronchiolitis, the effects of euthanasia, barbiturate euthanasia, the effect that has on the lung, and how to distinguish it from an antemortal finding. Antemortal be referring to something that would have happened before death, so that it's actually a lesion. And also I'll touch on especially embolisms, thromboses, and importantly atelectasis. To continue with that, we will also touch on cor pulmonale, pneumonia, the parasites that affect the lungs, and especially, very important, the virus-associated neoplasia that affects small ruminants in South Africa. Most of the work that I will present in the video presentations would basically be the more simpler or less advanced and less complicated matters. Just to give you an idea, a quick recap of terminology that you may have brought in from previous organ path, and especially from general pathology, just to extend it into respiratory pathology and how that fits in. So to start off, if you look at bronchitis and bronchiolitis, the difference between these is that bronchitis is basically inflammation of the bronchi. Bronchiolitis is inflammation of the bronchioles, right? And bronchitis can obviously then lead to bronchiolitis. And often the type of exudate that you get will be a catarrhal exudate because of the hyperplasia of submucosal glands and goblet cells, resulting in excess production of mucus. And that's when you see that serous catarrhal exudate coming from the nostrils often. There's quite a few etiologies for bronchitis, as you can see on the screen. Bronchiolitis often is an extension of bronchitis because, as I mentioned earlier, bronchitis is inflammation of the bronchi. Bronchiolitis is inflammation of the bronchioles. So when you've got a bronchitis that doesn't clear, it eventually can extend and the severity becomes worse, obviously, and then extends to the bronchioles. Okay, and obviously, if you look at the different viral etiologies that can cause a bronchiolitis or bronchitis, would be your syncytial virus infections, herpes virus, canin distemper. You can even get your fog fever, which is basically a pneumotoxin-induced pneumonia caused by 3-methyl-indole, and allergic responses, as I alluded to earlier. Habitual dyskinesia, often you will get pulmonary edema. The important thing there is just to make sure you're able to recognize that not all pulmonary edema would be a lesion. So if you've got a history that the animal had been euthanized using barbiturates, then chances are the pulmonary edema you see is because of the euthanasia. However, you can always, if you think it's a lesion associated with all the other typical changes that you would expect with edema, whether it's because of inflammation or hyperproteinemia, and then obviously be able to work back and be able to come to a conclusion as to whether the inflammation that you're seeing is because of an antemortem finding or because of terminal agonal findings. As you all know, lungs are very vascularized, hence the beautiful pink color that you often get with lungs. And the different types of redness that you can get on a lung, if it's like a diffuse redness, can either be because of congestion or because of inflammation. Remember the active and passive, the difference between the two. Whether it's a stagnation of blood and then being congestion, or it's because of inflammatory mediators, the blood is being pulled into that area. And as I mentioned already, stagnation of blood in pulmonary vessels is basically a definition of pulmonary congestion. And there's different types of causes as listed below. Sometimes with pulmonary congestion, you can get aggression of erythrocytes into alveolar spaces. If they've been sitting there for quite a while, this will happen through diapedesis, and often what you'll find is that macrophages will go through into the alveolar spaces and try to phagocytose all that edema and red blood cells that have now moved through the capillary walls. This is often a sign of chronic heart failure, and because of the red blood cells being phagocytosed by the macrophages, they get digested, and they often have a brown cytoplasm, which is basically breakdown of hemoglobin. The lung often will have like a discolored red, dirty brown color, and often doesn't collapse when the thoracic cavity is opened. And like I said before, your pulmonary congestion can be due to an acute death, habitual euthanasia, or it can actually be an antemortem. It's important that you're able to understand the concept of hypostatic congestion. This is something that affects often your large animals like your horses and your cattle. If they've been in lateral recumbency, or for example with surgery, down a cow, what happens is that because of the effects of gravity and poor circulation of the lung, and also the kidney is also affected in such a way, you get an accumulation of blood in that side of that organ. They become darker and firmer, and because of that, you can get the consequences thereof which is also pneumonia. So that's why epistatic congestion becomes edema, because that eventually leads to pneumonia through this edema and affecting basically the normal functioning of the clearing of the airways. In the normal lung, fluid slowly and continuously seeps out of blood vessels on a normal day-to-day. It passes into the interstitium, where it is then rapidly drained by the pulmonary and pleural lymphatics. However, when things go wrong, that's when you get edema. And that's when the rate at which the fluid accumulates in the alveolar spaces in the interstitium is greater than the rate at which the lymphatics in alveolar can actually remove it. Physiologically, edema can be classified as either cardiogenic or non-cardiogenic. You will see this is actually a basic recap of your general pathology. Remember vascular disturbances. The difference here, we're now applying it specifically to a organ, but the basis and the concept behind it is still the same. Hydrostatic pressure, the fluid is in the blood vessels and is forced out because of the pressure within the blood vessel being high. Oncotic pressure is decreased because protein in the blood, which keeps the fluid inside the blood vessel, is insufficient. Then the fluid leaks out of the blood vessels. Okay, I'm sure that rings a bell. Here we just look at the difference between cardiogenic and non-cardiogenic edema. The gross image or the macroscopic image of an edematous lung is quite typical. Now, obviously, edema occurs because of various reasons. It could be because of congestion, hemorrhage, inflammation, whatever process is going on, but it results in an overwhelming excess of fluid that the body can't deal with and getting rid of in time. The animal often presents with foam in the bronchi, which you'll see in the bronchial bifurcation. It can go all the way up the trachea, and sometimes the animal presents with foam coming through the nostrils as well as the mouth. On cut surface, the lung just oozes fluid, and especially in cattle and pigs, which have quite prominent septae and interlobular septae, those lobules become even more distinct because of the fluid that surrounds them. The lung will also often be quite heavy. Now think about it. There often is foam in the conducting system. This is not because the animal has decided to enjoy a bubble bath, no. However, the mixing of edema fluid, when there's an excess and when things have gone wrong, as I explained earlier, together with surfactant, which is normally present within the conducting system of the lung, as well as with air, causes then the bubbly appearance that we then see. The lobules of the cattle and pigs, like I already mentioned, become accentuated, okay? Because the vessels also are distended, because they're trying to get rid of the fluid that is now accumulated for whatever the reason it is. When the pulmonary edema is quite severe, sometimes it can be difficult to distinguish it grossly from peracute pneumonia. And that's because in the early stages of inflammation, you often do get edema. So if you've got a severe pulmonary edema, what you're looking at the lung can easily have been a peracutely inflamed lung that will also be edematous and hasn't gone through all the processes of becoming red. We'll also touch on pulmonary hemorrhage. In this case, we have an exercise-induced pulmonary hemorrhage that you often get with racehorses, and you can also get hemorrhage with blood splashing. For example, when an animal's throat is cut while it's actually still alive and can actually breathe in the blood that is released from the arteries and the jugulars, and then it goes and accumulates in the lung. Clinically, in this case, the animal presents with an epistaxis. So I prefer not to use epistaxis, the term, in pathology. I prefer the term or the description of a bloody nasal discharge. Epistaxis for me is a clinical term, and if the animal is dead, it's not really actively bleeding. It's just the blood that is already exited the blood vessels and is in the wrong place. The pathogenesis of exercise-induced pulmonary hemorrhage is controversial because normal horses will have some percentage of hemorrhage after a race or after excessive exercise, and then you won't even pick it up. They'll carry on as normal, it will be cleared and it will be fine. Whereas then you get other horses where you get the exercise-induced pulmonary hemorrhage and they actually die because they exsanguinate, basically. They bleed out. So regarding the pathogenesis thereof, yeah, that's still under investigation. I mentioned blood splashing earlier, which occurs through aspiration of blood when there's simultaneous severing of the trachea as well as the carotid arteries. Blood is then aspirated into. And often what you'll see is these feathery borders or indistinct borders of blood foci within the lung. And that often tells you that this is most likely aspirated blood. This is an important list to remember. It is often asked what to list the differentials for red, black, focal, multifocal discoloration of the lung. It's an important list. I repeat, it's an important list to know that if a lung is red, there can be many reasons why it is that color, and microscopically you cannot always distinguish between all of these listed here. But do know the list and make mental notes of it.